Welcome to the deep dive. Today, we're tackling something really fundamental, I think. Something we all live in, but maybe don't fully appreciate: our skin.
Exactly. It's our largest organ, after all.
Right. And
Yep.
we're not just scratching the surface today. Sorry, couldn't resist. We've got wound care essentials, practice principles here, and we're focusing specifically on the chapter Skin, an essential organ.
Yes. And you, the listener, shared some sources with us because you're looking to get a deeper understanding of the skin, what it does, its layers, how it changes over time.
So our mission for this deep dive is really to pull out the most crucial bits, maybe some surprising facts, those aha moments, and connect the dots in a way that's hopefully really clear and engaging.
Sounds good. Where should we start?
Okay, let's get into it. We'll kick off with the structure, the anatomy, which is surprisingly complex, actually.
Yeah.
Then we'll explore all the jobs it performs, which is like way more than just being a covering.
Yeah.
We'll also look at how skin changes as we age, both naturally and because of things like sun exposure. And finally, we'll touch on the basics of assessing skin, what to look for and what changes might mean.
Great. It should hopefully give everyone a new appreciation for their skin.
Let's hope so. So anatomy first. Its sheer size and importance is easy to overlook, isn't it?
It really is. I mean, think about it. It's the largest organ, our literal barrier between everything inside us and the whole outside world. But it's so much more than just a barrier.
Absolutely. Our source really highlights that protective role against physical trauma, water loss, chemicals, nasty microorganisms, mechanical stress, even radiation. It's incredibly resilient.
And it's not just a passive wall. It's actively working all the time. It's key for maintaining our water balance, controlling body temperature. Our sense of touch comes from there.
Right.
And it's even involved in making things like vitamin D and processing certain hormones. Pretty amazing, really.
It is. So how is this powerhouse actually built? The book points to two main layers, a really important junction between them, and then a deeper layer underneath.
That's right. You've got the epidermis on the outside, the dermis below that, the dermal-epidermal junction, often called the BMZ, connecting them, and then deeper still, the subcutaneous tissue, or hypodermis.
Let's start with the epidermis, the outer shield. You mentioned it's a vascular, no blood supply.
Correct. No direct blood supply. It gets its nutrients by diffusion from the dermis below. But what's really fascinating is how it's constantly renewing itself.
Like shedding.
Exactly. It completely regenerates roughly every 4 to 6 weeks. You know when you towel off after a shower and sometimes see little bits of skin? That's the very top layer, the stratum corneum. Those are dead cells shedding off.
Okay. So that's part of the process.
Yes, and that constant turnover is vital for its barrier function and for healing quickly from, say, minor scrapes.
And this epidermis, it's not just one sheet, is it? The source mentions several layers within it.
That's right, 5 distinct layers, or strata. From the outside in, you have that stratum corneum, the dead, shedding cells. Then, only on our palms and soles, a layer called the stratum lucidum.
Oh, interesting. Why only there?
It's related to the thickness and wear and tear in those areas. Below that, the stratum granulosum, then the stratum spinosum. These contain important immune cells called Langerhans cells too. And finally, the deepest layer, the stratum basal.
The engine room, you called it.
Sort of, yeah. That's where the new keratinocytes, the main skin cells, are constantly being produced. It also contains melanocytes, the cells that give our skin its pigment.
And these keratinocytes, they do more than just form layers, right? They react to damage.
Oh, absolutely. When the skin gets injured, a cut, a burn, too much UV chemical irritation, these keratinocytes just jump into action. It's like an emergency response.
How so?
They start dividing really fast. They actually migrate to cover the wound. And they even send out signals to other cells like fibroblasts in the dermis, those Langerhans cells, even the melanocytes, telling them to help with the repair process. Then once everything's fixed up, they basically go back to their normal job of maturing and moving up through the layers.
That's incredible coordination. Now, what about that connection point, the dermal-epidermal junction, the BMZ? The source uses a waffle iron analogy.
Yeah, it's a great visual. Imagine the bottom of the epidermis having these ridges, like fingers, called rete ridges or pegs, that slot perfectly into projections coming up from the dermis, like two sides of a waffle iron meshing together.
Okay, I can picture that. And why is that structure so vital?
It creates a huge surface area for connection and really anchors the epidermis firmly to the dermis. It stops them shearing apart. Without that strong bond, the skin would be incredibly fragile.
And this changes.
It does. It's actually not fully formed in premature babies, which is one reason their skin is so delicate. And importantly, as we age, this junction tends to flatten out. Those ridges get shallower.
So let's grip.
Exactly. Less interlocking surface area, maybe by as much as 50%, according to some studies. And that flattening is a major, major reason why older skin gets injured so easily. Think about skin tears from just a slight bump or friction.
Ah, that makes total sense. Okay, so moving deeper, we hit the dermis. The source calls it the true skin. What makes it the true skin?
Well, it's the thicker layer, and it provides the main structural support. It's packed with collagen for strength and elastin for flexibility, both made by cells called fibroblasts. It's really the substance of the skin.
And has layers, too.
Yes, two main ones. The upper papillary dermis, which is sort of wavy and forms our fingerprints, and contains tiny blood vessels, capillaries, and touch receptors. Then the deeper, thicker reticular dermis, made of dense collagen bundles, which anchors everything to the subcutaneous tissue below. That's also where you find the larger blood vessels, nerves, sweat glands, and hair follicles.
So it's the scaffolding, the plumbing, the wiring.
Yeah.
Everything's in there.
Pretty much. Beyond just the structure and delivering nutrients via those blood vessels, the dermis is crucial for retaining moisture. It protects the muscles and bones underneath. And don't forget the glands, sebaceous glands making sebum, that natural oil.
Or lubrication.
Yes, keeps the epidermis from drying out and cracking, helps maintain that barrier. And even the hair follicles rooted there have stem cells that can help repair the epidermis if it gets damaged.
Okay. And then the final layer, the subcutaneous tissue or hypodermis.
Right. Think of this as the foundation layer. It connects the skin to the structures underneath, like muscle and bone. It also holds a reserve of blood for the dermis, which is handy for healing.
And it's mostly fat, right? Adipose tissue.
Primarily, yes. Which provides cushioning against bumps, helps give our body its contours, and importantly, acts as insulation to help keep us warm. It allows the skin to move over the underlying structures, too.
It's just amazing how intricate it all is right from the beginning in embryonic development. The source mentions the different germ layers forming different parts.
Yeah, the ectoderm forming the epidermis and things like hair and nails, the mesoderm forming the dermis and subcutaneous layers, and even the neural crest contributing the pigment cells. It really highlights the complexity.
Definitely. And when you think about the skin as a whole organ, its roles go way beyond just the structure we've talked about.
Absolutely. Consider its weight and surface area. In an adult, it's significant. And its thickness varies hugely, too. Super thin on your eyelids compared to the palms of your hands or soles of your feet.
And the blood supply you mentioned earlier, a third of our circulating blood volume, that seems like a lot.
It is surprisingly high, especially considering its immediate metabolic needs aren't that intense compared to, say, the brain or muscles. But that blood flow is crucial for temperature regulation and healing.
Okay. And the book talks about the acid mantle, a pH of 4 to 6.5.
Right.
Why is that acidity important?
It's really key. That slightly acidic surface helps keep our normal skin flora, the good bacteria and fungi that live on us, happy and healthy. They actually help protect us from pathogenic or harmful microbes.
So it's like cultivating a good garden on your skin.
That's a nice way to put it. It also helps in forming the lipids, the fats, and the outermost epidermal layer, which are essential for the barrier. And lots of things can disrupt it. Alkaline soaps are a big one, overwashing. Even certain skin conditions like eczema or systemic issues like diabetes can make the skin less acidic.
So protecting that acid mantle is important for overall skin health.
Definitely. And beyond the pH barrier, the skin is actively producing its own antimicrobials called defensins. It's not just passive, it's fighting back.
It's also surprising, I think, that the skin is involved in hormones.
Yes, it's involved in converting some precursor hormones into active forms like testosterone and DHT in males. And it's actually a significant site for producing estrogen, specifically 17-estradiol outside of the ovaries.
Wow, okay. And sensation, of course, that's a big one. Touch.
Huge. Our interface with the physical world. And the sensitivity varies massively, doesn't it? Lips, nipples, fingertips are packed with nerve endings. Fingertips are amazing for stereognosis, identifying objects just by feel.
I read something interesting in the source shaving can reduce sensitivity.
Temporarily, yes, because many touch receptors are actually located right at the base of the hair follicles. So when you shave the hair off, you slightly reduce the input from those receptors for a bit. And in hairless areas, we have different receptors like Meissner's corpuscles, which are great at detecting light, pleasurable touch.
What about itch? That dreaded sensation. The book calls it an alarm.
Yeah, it's seen as a defense mechanism, often triggered by the same inflammatory chemicals released during injury or irritation. It alerts you that something's wrong. And there's a complex relationship between itch and pain pathways in the nervous system. They can actually suppress or enhance each other.
And pain itself. different types.
Right. You've got that sharp, quick, well-localized superficial pain, maybe from a paper cut, transmitted by faster A delta nerve fibers. And then the deeper, duller, longer-lasting ache, transmitted by slower C fibers. Even pressure sensation is protective. It warns us before damage occurs.
Okay, let's shift to temperature control and fluid balance. Sweating cools us down, obviously.
Right. Evaporation of sweat is a very effective cooling mechanism. But the skin's blood flow is also critical. The hypothalamus in the brain monitors our core temperature and uses signals from the skin.
How does the blood flow change?
When we're hot, blood vessels in the dermis dilate, widen, bringing more warm blood close to the surface to radiate heat away. Vasodilation. When we're cold, they constrict, narrow, keeping blood deeper and conserving heat. Vasoconstriction. It's a constant adjustment.
That makes sense. And other quick functions, the source mentions getting rid of some waste products.
A minor role in excretion? Yes. Preventing excessive water loss is huge, obviously. And that vitamin D synthesis when sunlight hits the skin, though it needs activation in the liver and kidneys later.
And immune functions, too.
Definitely. It's packed with immune cells, those Langerhans cells in the epidermis, macrophages, mast cells in the dermis. They're like sentinels, ready to react to invaders. Even the keratinocytes themselves release inflammatory signals if the barrier is breached.
And I mentioned we're more likely to get allergic reactions through the skin than eating something.
That's generally true for developing sensitization, yes. Skin exposure seems particularly potent for triggering allergic responses compared to oral ingestion for many allergens.
It really drives home how active and complex the skin is. Okay, let's talk about aging. The book differentiates intrinsic versus extrinsic aging.
Right. Intrinsic is the natural chronological aging process, the changes you'd see even in skin protected from the sun, driven by genetics and internal factors. Extrinsic aging is caused by external factors, primarily UV radiation from the sun, but also things like smoking and pollution.
But they're hard to separate completely.
Very hard, because lifestyle factors affect both, and genetics influence how susceptible you are to extrinsic factors too. But the main driver of what we typically see as aged skin wrinkles, spots, is extrinsic, mostly photoaging from the sun.
And the underlying mechanism involves oxidative stress, those ROS, reactive oxygen species.
Yes, that's a central theme in both types of aging. ROS are unstable molecules, byproducts of metabolism, but also generated by things like UV light. They damage cellular components, DNA, proteins, lipids.
Like cellular rust.
That's a decent analogy, yeah. And as we age, our production of ROS tends to increase, while our antioxidant defenses and DNA repair systems become less efficient, so the damage accumulates.
And UV light, smoke, pollution, they just pour fuel on that fire.
Exactly. They directly generate huge amounts of ROS, overwhelming the skin's defenses. This leads to inflammation, breakdown of collagen by enzymes called MMPs, damage to the mitochondria, the cell's powerhouses, and DNA mutations that can lead to cancer.
The source also mentions telomere shortening.
Yes, telomeres are protective caps on the ends of our chromosomes. They naturally shorten a bit each time a cell divides, acting like a clock. But oxidative stress from UV, pollution, even psychological stress can accelerate that shortening. When they get too short, the cell stops dividing or dies, contributing to aging.
So what are the visible and functional changes that happen to the different layers as skin ages? Let's start with the dermis.
Okay, the dermis gets thinner, maybe losing about 20% of its thickness over time. Fewer fibroblasts, less collagen, and the collagen that's left is often disorganized and changes type. Less elastin, too. Fewer blood vessels, fewer nerve endings.
And the result is?
Skin looks thinner, more fragile. Sensation can change. Temperature regulation isn't as good. It loses firmness, doesn't hold moisture as well, and you get sagging and wrinkling.
What about the epidermis, the outer layer?
Turnover slows down. Cells don't regenerate as quickly. The surface pH tends to become less acidic, making it more vulnerable. Shedding of dead cells isn't as efficient. Lipid production decreases, so the barrier weakens. Fewer melanocytes mean less natural sun protection, and fewer Langerhans cells mean a weaker immune response right at the surface. Plus, there's often a low-grade chronic inflammation present in aged skin.
And that all-important junction, the BMZ.
That flattens, as we discussed. The ridges smooth out, reducing the interlocking grip between epidermis and dermis. This is a huge factor in age-related skin fragility and skin tears.
And the subcutaneous fat layer.
That tends to atrophy, but it's site-specific. You often lose fat in the face, hands, shins, soles of the feet. This reduces cushioning, making bony areas more vulnerable to pressure and injury, and affects insulation too. Less padding means more impact energy gets transferred during a bump or fall.
Are hormones linked to these changes?
Yes, definitely. The decrease in estrogen after menopause is clearly linked to decreased collagen, thinner skin, drier skin, and slower wound healing. Some studies suggest hormone replacement might partially reverse some of this. Androgens seem to play a role too, possibly influencing things like venous ulcers.
What about sensation changes?
There's a decrease in the number of specialized touch receptors, like Meissner's and Pacinian corpuscles. So sensitivity to light touch, pressure, and vibration often diminishes. Crucially, pain perception can also decrease, which sounds good, but actually makes older adults more vulnerable because they might not notice an injury as quickly.
And vitamin D production.
The skin's ability to synthesize vitamin D from sunlight exposure significantly decreases with age.
Immune function overall.
Also generally declines. Fewer Langerhans cells, fewer mast cells. And medications commonly used by older adults, like steroids, can further suppress skin immunity and cause thinning.
Other things, like oil production, temperature control.
Yeah, fewer active pilosebaceous units mean less sebum, contributing to dryness. Thermoregulation is impaired due to that subcutaneous fat loss, reduced blood flow changes, and fewer sweat glands. Moisture retention suffers because of changes in dermal proteins. Stretchability decreases with elastin loss. The thinner epidermis is just a less effective barrier overall.
And blood vessels, they seem more prominent or fragile sometimes.
Yes, the small blood vessels in the dermis become more fragile because there's less supporting collagen around them. This leads to easy bruising, often called senile purpura, those reddish-purple spots, usually on the forearms or hands, that fade to a brownish color from hemosider and staining. Sometimes you can even get larger collections of blood, dissecting hematomas, especially on sun-damaged skin or if someone's on blood thinners.
So a lot of these changes are accelerated by the sun, right? That's photoaging versus just intrinsic aging.
Hugely accelerated. Sun exposure, UV radiation, is the #1 extrinsic factor. It causes inflammation, suppresses the local immune system in the skin, and directly damages DNA. Both UVA and UVB contribute.
What's the difference again between UVA and UVB?
UVB is the main culprit for sunburn and most skin cancers. UVA penetrates deeper, contributing significantly to photoaging wrinkles, leathery texture, brown spots, and it also enhances the cancer-causing effects of UVB. UVA can even penetrate window glass.
Yikes, so photoaged skin looks quite different.
Oh, yes. It's often described as coarse, rough, deeply wrinkled, maybe yellowish, elastosis, with uneven pigmentation, broken blood vessels, telangiectasias, and it's much more prone to precancerous and cancerous growths.
Which brings us to sun protection. What's the advice?
Use a broad-spectrum sunscreen, meaning it covers both UVA and UVB. Look for SPF 30 to 60 for UVB protection and reapply it every couple of hours, or more often if you're sweating or swimming.
Broad spectrum is key then, not just SPF number.
Yeah, absolutely. And if people have allergies or sensitivities to chemical sunscreens, physical blockers like zinc oxide or titanium dioxide are good alternatives. Plus, sunscreen isn't the only thing. Wear protective clothing, a wide-brimmed hat, like 3-inch brim, sunglasses, and try to limit direct sun exposure during peak hours, roughly 11 a.m. to 3 p.m.
Okay. What about those specific skin changes caused by sun damage? Precancers.
The most common precancer is actinic keratosis, or AK. It usually looks like a small, rough, scaly, reddish patch or papule on sun-exposed areas like the face, scalp, ears, hands. They can sometimes develop into squamous cell carcinoma if left untreated.
And actual skin cancers.
Bowen's disease is like a larger AK, sometimes called squamous cell carcinoma in situ. Then there's invasive squamous cell carcinoma, SCC, often a firmer, red, keratotic papule or nodule, maybe tender. Basal cell carcinoma, BCC, is the most common type. Often looks like a pearly or waxy bump, maybe translucent with tiny blood vessels, can bleed easily, and might develop a central crust or ulcer.
And melanoma.
The most dangerous type, yes. We'll get to the ABCDs in a moment. But it's worth remembering that even one blistering sunburn, especially in childhood or adolescence, can significantly increase your lifetime risk of all types of skin cancer, including melanoma.
That's sobering. The source mentions a two-cheek test.
Yeah, it's a simple visual comparison. You compare the skin on a habitually sun-exposed cheek with the skin on the buttock cheek, which is usually protected. The difference you see really highlights the impact of photoaging versus natural intrinsic aging. It can be quite stark.
Okay, and the melanoma ABCDs. What should people look for?
A is for asymmetry. One half of the mole doesn't match the other. B is for border irregularity. Edges are ragged, notched, or blurred. C is for color variability. Mole has different shades of brown, black, tan, or even patches of red, white, or blue. D is for diameter usually larger than 6 millimeters, about the size of a pencil eraser, although melanomas can be smaller. Some sources add E for evolving any change in size, shape, color, elevation, or new symptoms like bleeding or itching.
That's really important to know. Okay, shifting gears slightly, how do we actually assess the skin? What are the key things to look at?
Well, a basic skin assessment gives you a snapshot of someone's general physical condition. It involves looking closely inspection and feeling palpation.
What about a history?
Crucial. You need to ask about allergies, skin products, medications, topical treatments, even foods. Also, their usual skincare routine, how often they bathe, what soaps or lotions they use.
And then observation. Just look everywhere.
Pretty much. You ideally want to look at the entire body surface, including nails, scalp, hair, and mucous membranes if relevant. Good lighting is essential.
What are the absolute minimum things to check?
The source lists 5 key parameters, often remembered by the acronym TMMI or similar: temperature, color, moisture, turgor, and integrity. Is the skin intact, or are there wounds or lesions?
Okay, temperature, how do you check that?
Usually use the back of your hand and compare side to side, like both feet or both arms. Feel for warmth, which might indicate infection or inflammation, or coolness, which could suggest poor blood supply. Non-contact infrared thermometers are also used now.
Color seems obvious, but the source mentions challenges.
Yes, assessing color changes can be tricky, especially in people with darker skin tones. You need good lighting, and sometimes you need to look at areas with less pigment, like the palms, soles, nail beds, or mucous membranes. Knowing the person's baseline color is important.
And the Fitzpatrick scale.
Right, that classifies skin types, the itemii, based on how they react to UV light burning versus tanning. It helps anticipate risks, but doesn't replace individual assessment. You also look for specific changes. Jaundice, yellowing, suggests litter issues. Pallor could be anemia, redness or flushing might be fever, inflammation, or alcohol effect. Post-inflammatory pigment changes, lighter or darker spots after injury or inflammation, are also common, especially in darker skin.
Okay, moisture balance. Not too dry, not too wet.
Exactly. The stratum corneum, that outer layer, needs about 10–15% water content to function properly. Too little, and you get xerosis, dry, flaky, scaly skin.
What causes dry skin?
Lots of things. Low humidity, harsh alkaline soaps, overbathing, especially with hot water, certain conditions like hypothyroidism, and just normal aging, we lose oil and sweat glands.
And too much moisture.
Leads to moisture-associated skin damage, or MSD. Think diaper rash or skin breakdown under skin folds or around leaky wounds, but focusing on dryness or xerosis.
Yeah, that seems really common, especially in older adults.
Very common. It can range from mild flaking to severe cracking and inflammation. While it's not usually diagnostic of one specific disease, you need to figure out why it's happening. The goal is to protect the skin from losing more water, that's transepidermal water loss, or TEWL, and to replenish its natural moisturizing factors, mainly lipids.
So lotions and creams.
Yes, but also education is key. Teach people to avoid long, hot baths or showers. Maybe bathe less frequently. Use tepid water. Choose gentle, pH-balanced cleansers instead of harsh soaps. Pat skin dry instead of rubbing vigorously. And apply a good moisturizer immediately after bathing while the skin is still slightly damp to trap moisture.
Any other tips?
Using a humidifier in dry environments helps. Drinking enough water is important for overall hydration. Sunscreen is always good. Avoid products with fragrances or harsh chemicals if sensitive, and apply moisturizers gently but frequently throughout the day. The aim is to stop the xerosis cycle.
Xerosis cycle.
Yeah, dry skin often leads to itching or pruritus. Scratching the itch damages the skin barrier further, which makes it drier and more prone to inflammation and infection, which then makes it itch more, and round you go. It's the itch, scratch, itch cycle.
Ah, okay. So pruritus or itching is often linked to dry skin.
Often, yes, but it can also be a symptom of underlying systemic diseases like kidney or liver problems, or skin conditions like scabies, or just part of aging. So a good history is vital if someone has persistent itching.
And the problem with the scratching isn't just the damage.
Right. Scratching breaks the skin, increasing infection risk. Chronic scratching can also lead to lichenification, where the skin becomes thick, leathery, and hyperpigmented from the constant rubbing.
So how do you manage itching?
Break that cycle. Treat the underlying cause if possible. Use good, long-lasting moisturizers, sometimes cooling them helps. They need to soothe the skin and help restore that damaged barrier. There are specific ingredients to look for depending on the need: humectants to draw water, emollients to soften, occlusives to seal moisture in. The source has tables detailing these.
Okay, next parameter, turgor. What is that exactly?
Turgor reflects the skin's elasticity and hydration status. It's how quickly the skin snaps back after being pinched.
How do you test it?
Gently pinch a fold of skin, usually on the back of the hand or over the sternum, hold for a few seconds, then release. Normally, it should return immediately.
And if it doesn't?
If it returns slowly, taking more than, say, 3 seconds, that indicates decreased turgor, often a sign of moderate to severe dehydration. However, in older adults, skin naturally loses elasticity, so checking turgor on the hand can be misleading. It might seem poor even if they're hydrated. Checking over the sternum is often better in that case.
Can anything else affect turgor?
Yes, conditions that cause skin thickening or fibrosis can also decrease turgor, making the skin feel stiff or woody. This happens in advanced venous disease with lipodermatosclerosis in the lower legs. There's also stemmer sign. If you can't pinch the skin on the top of the second toe, it's a strong indicator of lymphedema in that leg.
Okay. And the last minimal parameter was integrity.
Right. Basically, is the skin intact? Or are there lesions, wounds, breaks? You need to document any alterations, rashes, specific lesions, scars, bruises. That senile purpura we talked about, brownish hemosiderin staining from old blood leakage, often seen in venous insufficiency, or swelling, edema.
Nutrition plays a role here too, right?
Big time. Various vitamin and mineral deficiencies can manifest as skin changes, like severe vitamin A deficiency can cause dryness, B vitamin deficiencies can cause various rashes or sores, lack of vitamin C impairs healing. Good nutrition is fundamental for skin health and repair.
The source mentions primary and secondary lesions.
Yes, primary lesions are the initial presentation like a blister, a macule, flat spot, a papule, raised bump. Secondary lesions develop from primary ones, maybe due to scratching, infection, or healing like a crust, a scale, an ulcer, or a scar. Using the correct terminology to describe lesions is important for communication. You should also feel them. Are they tender, firm, deep? And measure them if necessary.
What about scars?
A scar is fibrous tissue that replaces normal skin after an injury. It's part of natural healing. You should note why it's there, where it is, what it looks like, color, size, raised flat, and if it's tender. One specific type mentioned is atrophy blanche, small, white, star-shaped scars, often with tiny red dots, telangiectasias around them, typically seen on the lower legs in areas of healed ulcers related to venous disease or livedoid vasculopathy. Most wounds, though, will result in some kind of scar, and scar tissue is always weaker than original skin.
Okay, and edema swelling.
Right, abnormal fluid accumulation in the tissues. Common in hands, arms, ankles, legs, feet. Often related to problems with the venous or lymphatic systems, but can also be caused by heart failure, low protein levels, from poor nutrition, liver or kidney disease, or other systemic issues. It can be localized or generalized anosarca.
How do you assess edema?
Compare limbs for size differences. Then press firmly with your thumb over a bony area, like the shin or ankle, for about 5 seconds. If an indentation remains after you lift your thumb, that's pitting edema.
And you rate it.
Yes. Often on a scale, like 1 to 4 + 1, based on how deep the pit is and how long it takes to disappear. Facility policies vary, but consistency is key. Managing edema involves treating the cause, maybe elevation, careful positioning, compression if appropriate, and meticulous skin care, because edematous skin is fragile and prone to break down.
The source also highlights nail assessment, specifically for fungal infections. Onychomycosis.
Yes, it's considered part of a comprehensive skin assessment, especially in older adults or people with diabetes, as it's very common. It's usually caused by dermatophyte fungi, more often affects toenails than fingernails.
What does it look like?
Nails become discolored, whitish, yellowish, or brownish. They often get thick, brittle, crumbly, distorted. Can be painful and make nail care difficult. Importantly, it's considered a significant risk factor for more serious foot problems, like ulcers and gangrene, particularly in people with diabetes.
So it's not just cosmetic.
Definitely not. Treatment usually involves topical or oral antifungal medications, which can take a long time. Good foot hygiene, keeping feet clean and dry, wearing cotton socks, breathable shoes helps prevent it.
There's also a brief mention of skin failure. That sounds serious.
It is, but it's a somewhat controversial concept in wound care. The idea is that, like any other organ, the skin needs oxygen and nutrients delivered by the blood. In severe systemic illness like multi-organ failure or near the end of life, the body might shunt blood away from the skin to preserve core organs. This lack of perfusion can lead to skin breakdown that might look like a pressure injury but is actually due to the systemic failure. It complicates discussions about pressure injury preventability in very ill patients.
Okay, that's a lot to cover in assessment. Let's quickly touch on the patient scenario provided.
Right. The 20-year-old woman with onychomycosis. Thickened, painful, discolored nails, scaly skin. Likely got it from frequent pedicures. Tried over-the-counter topicals without success. Diagnosis confirmed. Started on a proper topical antifungal regimen, solution, cream, shoe spray, and crucially received education on applying it correctly and consistently. After 6 months, it cleared up. It highlights the importance of correct diagnosis and adherence to treatment.
Good example. And the source ends the chapter with some show what you know, multiple choice questions for self-assessment.
Yes, a good way to check your understanding.
Okay, so to wrap up this deep dive, what are the main takeaways?
Well, I think the biggest one is that the skin is just so much more than a simple covering. It's this incredibly dynamic, complex organ with absolutely vital roles: protection, sensation, regulating temperature and fluids, even making hormones and vitamin D.
And its structure is key to all that. The constantly regenerating epidermis, the supportive dermis, that crucial interlocking junction.
Exactly, and understanding how both natural aging and environmental factors, especially the sun, change that structure and function is really important for proactive care. Those changes impact everything from barrier function to healing ability.
Which highlights the importance of observation, right? That basic assessment checking temperature, color, moisture, turgor, integrity can tell you a lot about overall health.
Absolutely. And recognizing common issues like dry skin, xerosis, or itchiness, pruritus, understanding that itch-scratch cycle, and knowing how to manage them with proper cleansing and moisturizing can make a huge difference to comfort and prevent bigger problems.
It really makes you think. Considering how complex this organ we see every day actually is, what other simple parts of our biology might be holding similar depths that we often overlook?
That's a great question to ponder. The interconnectedness of our body systems is truly profound. There's always more to learn and appreciate.